Good afternoon, everyone. My name is Will Fisher. I'm here with Social Security Works today, and I want to welcome you to this afternoon's webinar on Medicare privatization. This briefing will focus on the dangers facing your constituents through the advancing privatization of Medicare, both through Medicare Advantage and traditional Medicare. This webinar is being recorded, but we will turn off recording ahead of the Q&A. If you have any questions, I would ask that you go into the chat and enter those questions there, and we will get to the questions that we're able. And with that, Cameron and Rachel, over to you.
Hey, everybody. Welcome to today's panel on privatization of Medicare. I'm Cameron MacPherson with the Office of Congresswoman Katie Porter, and I'll let Rachel introduce herself.
Hi, everyone. I'm Rachel Madley with the Office of Representative Pramila Jayapal.
Great. So today we'll be discussing ongoing trends in Medicare that are leading an increasing number of beneficiaries to receive Medicare benefits through private entities. So we're excited to be joined by two Medicare and insurance experts for this conversation, Diane Archer from Just Care USA and Wendell Potter from the Center for Health and Democracy. So while private plans have long been a component of Medicare benefit delivery, Medicare Advantage, originally known as Medicare Part C, was created first in 1997. The premise of Medicare Part C was simple. If you introduce private market innovation into an expensive public program, savings would result. To facilitate this innovation, CMS established a payment system that differs from traditional Medicare's fee-for-service model. Using capitated payments, plans in Medicare Part C are provided money upfront to deliver care. Now, the amount CMS pays plans is calculated based on multiple factors, including the patient pool's risk score, an assessment of how much providing care for the population of patients will cost, and a benchmark that purports to save CMS money in exchange for these private plans providing care. But several problems have emerged with Medicare Advantage. First, as Rachel will describe, she's the expert in this problem, plans have gamed the system, making patients appear sicker than they are in an attempt to earn more money from CMS. Through this process called upcoding, CMS pays plans for money for costly care that patients do not receive because it was never required in the first place. Second, as MedPAC has noted, Medicare Advantage has failed to produce savings in any year since its inception. In fact, Medicare would generate an average of 4% savings per person if beneficiaries enrolled in Medicare Advantage plans instead received care through traditional or original Medicare. Third, the capitated payment system has resulted in fee-for-service by a new mechanism in a way. Private plans replace CMS as the entity responsible for negotiating payment rates for services delivered. In addition, the misaligned incentive structures lead many Medicare Advantage plans to introduce cumbersome prior authorization requirements that limit the amount of care that plans pay for or provide. And that leads to our final point, which is that Medicare Advantage plans have failed to produce data that would allow consumers, regulators, or lawmakers to assess the quality of care that these plans deliver. In a widely publicized recent report, which we will discuss in more detail shortly, the HHS Inspector General found that improper denials of care in Medicare Advantage caused significant harm to deliveries and actually impacted patient outcomes. As Medicare Advantage comprises an ever-growing share of people enrolled in Medicare coverage, Congress is unable to assess whether continued investments in the program are worthwhile. So before we hear from our experts to dig into these points in more detail, I want to turn it over to Rachel for some additional information.
Thanks, Cameron. And so I'm just going to build off of what Cameron said and talk about how the lack of transparency and the misaligned incentives in the Medicare Advantage model as it stands currently lend itself to upcoding. Now, upcoding happens when a extra diagnosis code or codes are added to a patient's medical chart to increase the number of codes. And this is a rampant problem in Medicare Advantage because of the capitated payment model. So when a payment goes from the Medicare Trust Fund to a Medicare Advantage organization, it is risk adjusted. So patients who are sicker are going to be paid a larger payment to the Medicare Advantage company because theoretically it will cost more money to care for a sicker patient. However, now there is this incentive to make your patients look sicker by adding codes to their chart that they're not being treated for and they actually may not even have. One recent example of this that really sticks out came from a whistleblower who actually said that her Medicare Advantage organization forced them to add codes that were so egregiously wrong, such as a prostate cancer code to a female patient's chart in order to get more money from the Medicare payments to Medicare Advantage. And when we think about upcoding in the mix of a lot of Medicare fraud that we see, we have to remember that the magnitude of this upcoding problem results in hundreds of billions of dollars of overpayments to Medicare Advantage companies over decades. And this is money that could be used in Medicare to lengthen trust fund solvency, to make fixes that are really needed to Medicare, to add additional benefits and more. So this is money that we are overpaying to Medicare Advantage organizations, but if we had that money actually going toward care for seniors, we could improve the care of all of our seniors who get Medicare benefits. Now, the money from these overpayments does not translate into better care, as Cameron was talking about. So research has shown from the data that we are able to get from Medicare Advantage companies that sicker patients and patients near end of life have to switch back to traditional Medicare to get the healthcare that they need. And the new Health and Human Services Office of the Inspector General report demonstrates that Medicare Advantage organizations are inappropriately denying care to beneficiaries. So these Medicare Advantage plans are getting way too much money for the care that they're providing to patients, and they're not using that extra money to improve the care that those beneficiaries are getting. Now, there is an issue of a similar problem happening in traditional Medicare right now, and that is occurring in the new ACO REACH model that the Center for Medicare and Medicaid Innovation has undertaken, previously known as direct contracting. And many of your bosses signed on to a letter that went to HHS urging them to stop the direct contracting program because it's opening the door for Medicare Advantage companies to do similar things in traditional Medicare. So we don't have these problems under control in Medicare Advantage right now. We don't have the transparency needed, and we definitely should not be opening the door to allow them into traditional Medicare under the ACO REACH model. And as Cameron and I will talk about later, there is a lot that we can do as Congress, but also that the administration can do to make sure we're protecting our seniors and make sure that they are getting all of the healthcare that they need under Medicare and to stop these issues in Medicare Advantage. So now I'm excited to hand it off to Diane Archer, who is founder and president of Just Care USA, who is going to talk more and really get into the weeds of what is happening with Medicare privatization and how it's leading to undertreatment and harm to patients. So Diane?
Thank you, Rachel, and thank you, Cameron. I'm not sure if I can add anything. You guys have really done a great summary of the issues. Thanks, everyone on this Zoom for your time and interest. We really do have a critical undertreatment problem. I'm going to focus first on Medicare Advantage, and that's according to the OIG, as Rachel alluded to, the American Medical Association, the American Hospital Association, and many others. And we know that undertreatment results in poor health outcomes and sometimes even death for patients, but we have no data on the numbers or on which Medicare Advantage plans are ensuring people get needed treatment and which aren't. And undertreatment results in part from the way the Centers for Medicare and Medicaid Services pay Medicare Advantage plans. As you know, MA plans have an incentive to spend as little as possible on costly care to maximize revenues. They get to keep a lot of the money they receive that they don't spend. Or put differently, their capitated payments are unrelated to the amount they spend on care, as Rachel was explaining. Capitated payments also provide a financial incentive for Medicare Advantage plans to create inappropriate administrative barriers to care. These barriers undermine swift access to care. Barriers include prior authorization rules that can be out of sync with standard medical practice, as well as just inappropriate delays and denials of care, according to the OIG, the AMA, and the AHA. A recent OIG report finds that 13% of care denials in Medicare Advantage plans overall are inappropriate. It doesn't name names, though. Doctors polled by the AMA say that prior authorization rules can lead to serious and sometimes deadly consequences for patients. And the OIG report also suggests that CMS is not vetting Medicare Advantage plans' prior authorization rules appropriately, if at all. And as a result, they're in place and they may be not appropriate. And we need these rules to be open to public scrutiny so that the plans are accountable for them if they don't have merit. Capitated payments can also lead to poor quality care through limited networks that can undermine access to high-value specialty care providers who are often out of network, as the Kaiser Family Foundation has reported. With private Medicare Advantage plans, we have enough data to know there's a big problem and too little data to know a lot of specifics. Because CMS allows a lot of MA plan activity to be considered proprietary, there's no transparency to know how different plans are behaving in terms of out-of-pocket costs for enrollees, denials, delays, prior authorizations, and a lot more. You wouldn't think of buying a car that hadn't had the engine and brakes inspected, or a house without checking for termites and other infrastructure issues. So it's hard to understand why Medicare Advantage plans are not required to disclose this critical information and why it isn't vetted really thoroughly and people alerted to the information. Poor access to care can mean needless death, as we all know. We urge you to find out why CMS renews contracts with Medicare Advantage plans found to engage in routine inappropriate denials of care, which endanger the lives of some enrollees. We also urge you to find out why CMS renews contracts with plans which year after year violate requirements to disclose complete and accurate encounter data, preventing MedPAC from assessing plan quality. What are these Medicare Advantage plans hiding? If this is about bad data collection systems, that speaks poorly of their ability to manage care. Why isn't CMS naming the bad actors so that people can make meaningful choices about whether to enroll in these plans? CMS needs to hold Medicare Advantage plans to account and penalize them in a meaningful way for bad acts. Of course, Medicare Advantage plans are all different. Some are far better than others. But again, the capitated payment model results in none of them actively marketing to people in Medicare with complex conditions like cancer and heart disease, people who are the highest cost patients. I always say that I would join a Medicare Advantage plan immediately if it was out there saying, we want you if you have cancer. But really, they only want you if you want a free gym membership. They're looking for healthy people. And that's not a system that is designed to meet the needs of a lot of vulnerable people with Medicare. So the question is, are they meeting those needs? In traditional Medicare, as Rachel said, we have related concerns with direct contracting, now called REACH, a traditional Medicare experiment in which people are enrolled unknowingly and without their consent if their primary care doctor works for a direct contracting entity, or REACH. Sorry, my phone is ringing. DCEs work a lot like Medicare Advantage, with insurer and private equity middlemen paid a capitated rate to oversee people's care. They now cover about 1.4 million people in traditional Medicare and are growing quickly. But we have no way of knowing whether the people in these DCEs are going to get the care they need. And given what we've seen in Medicare Advantage, we're concerned. How will CMS know? We don't yet know whether DCEs are ensuring people get the right care at the right time. That's the goal. But we do know that profits come first when Wall Street firms are involved. And we know that a capitated payment model leads to the same worrisome incentives as a Medicare Advantage. Also, while people in the direct contracting experiment can see any doctor they want, which is a great protection, we're concerned they may not be aware of that, and they may be told to drop their Medigap so that they can't go out of network because it's unaffordable, or they might misleadingly be steered into a Medicare Advantage plan where the direct contracting entities, REACH entities, see more dollar signs. We don't know, but we don't know how to protect people in these instances. And finally, we're concerned that CMS doesn't have the resources to effectively monitor all these DCEs. There are 99 of them now, and there are many more to come in 2023. So how we stay on top of that is really a big question. So in sum, I guess I feel like we need to do 6 things. We need to ensure that no insurer, no private insurer, can offer a Medicare Advantage plan that imposes inappropriate barriers to care. We need to ensure that all Medicare Advantage encounter data, as well as prior authorization rules, are available for public scrutiny. As you may know, MedPAC has said for years they can't assess quality in Medicare Advantage overall, let alone at the plan level, because they don't have good data. And without data, we have inadequate assurances that people are getting the care they need. We need to ensure that CMS can hold health insurers and other corporate entities accountable for bad acts. Today, serious violations are not adequately addressed. It's a small number of dollars that these plans pay. It's nothing. Contracts with bad actors should be canceled to save thousands of lives a year, as one recent NBER, National Bureau of Economic Review report urged. We need to ensure that CMS names the bad actors. Right now, the most vulnerable people in poorest health and Medicare Advantage plans are at serious risk, or they could be. We need to ensure that people are not locked into Medicare Advantage, as Cameron mentioned, and can switch to traditional Medicare without assuming unlimited financial risk. And we need to overhaul the capitated payment model so that payments relate to the cost of services Medicare Advantage plans deliver to better ensure that people get the care they need. Thank you all for your time again. And over to you, Wendell.
Thanks so much, Diane. And thank you all. This is really quite a thrill for me. I am so grateful to have this chance. I have been in and around Washington for a long time. I first came to DC in 1976. That was soon after I graduated from kindergarten. And Scripps Howard newspapers had promoted me from Nashville, where I was covering the Tennessee legislature, to cover Congress and the White House. That was certainly a thrill. One of the biggest moments of my life was to be able to do that. When I got there, one of the things that was talked about a great deal and anticipated every month was something that the late Senator William Proxmire did. Proxmire, the year before, had launched the Golden Fleece Award, which, as you may know, it pilloried government agencies for extravagant spending of taxpayer dollars. And those of you who were not around then probably still have heard about some of Proxmire's awards over the years. Among them was a $300 hammer and a $600 toilet seat that came out of inflated Reagan-era defense contracts. Well, folks, we need another William Proxmire. If he were alive today, I have no doubt that he would go after the Center for Medicare and Medicaid Services for the truly massive overpayments that CMS has made to health insurers, mostly for-profit health insurers that participate in the Medicare Advantage program. I left my career as a Washington correspondent to go into corporate PR because it paid more. And I wound up working for 2 of the largest health insurance companies in the country, Humana and Cigna. Humana was one of the very first of the big insurance companies to begin luring Medicare beneficiaries into their private Medicare plans under what was then called Medicare Plus Choice. As Karen mentioned, the program was started in '87. I joined Humana in '89, and Humana was significant, a very big player, probably the biggest player in that program at that time. Other companies were seeing that Humana was making some money, and among them was Cigna, where I went to work after leaving Humana. I worked there for 15 years. In the late 1990s, however, after Cigna and Aetna and other companies got into Medicare Plus Choice, they began to complain that they weren't making quite enough money. So in the late 1990s, Cigna, Aetna, and other insurers decided that the government was just being too stingy with taxpayer dollars. One of the worst days of my career in the industry was the day that my team had to announce that Cigna was going to be pulling out of every one of its Medicare markets except one, and that was in Phoenix, where it had a longstanding presence in the market there. Exactly 22 years ago today, on June the 3rd, 2000, the Los Angeles Times carried a story that quoted someone on my team as saying that Cigna would be abandoning the Medicare market which would be forcing more than 100,000 seniors nationwide to find new health insurance. That move was going to be that was going to become effective on January the 1st, 2001. And as the Times reported, it was expected to be followed by other managed care companies, which had begun scaling back their Medicare participation. Aetna, which at that time was called Aetna US Healthcare, covered 650,000 people. It was a much bigger presence in the Medicare market than Cigna at that time. But it too came to reduce its participation in that program. Pacificare and other companies, some that you have probably don't even remember their names because they merged or had been acquired by other of the big insurance companies, were getting out of the market. That led to Karen Ignani, who was at that time president of the American Association of Health Plans, now known as AHIP, said that the program is in free fall. We are in the middle of a real crisis. And the LA Times reported that health plans had dumped 750,000 Medicare beneficiaries from the rolls from 1998 to 2000. Cigna had gradually been losing money, presumably, on the Medicare operations. Frankly, it just wasn't making enough money to satisfy its investors. Previously, it had covered as many as 190,000 Americans. The guy on my team who was quoted in that story, Howard Drescher, was quoted saying that he did not rule out a return to the Medicare business if the federal government sweetens its reimbursement, or, as President Clinton has proposed, begins to pay for prescription drugs, which health plans have been lobbying furiously for some time. But as the story noted, the Federal Healthcare Financing Administration, you might remember that name from back in the day, it was running Medicare and Medicaid, said that it is the health plans, not the government, that are causing the problem. Nancy Ann DeParle, administrator for HCFA, which now is CMS, accused health plans of spending too much money on unnecessary perks, such as low or no cost plans with rich benefits in order to grab patients from other providers. While private sector Medicare HMOs are paid more than enough to provide the basic Medicare benefits, the payment formula set by law doesn't always pay enough for the extra benefits they use to entice beneficiaries and make enough profit. Now, can you imagine if the current leader of CMS would say something like that? And I've known Nancy Ann for a long, long time because she and I are UT graduates, and she went on to better things than I went on to. She was also a Rhodes Scholar. Anyhow, switching seniors to Medicare Advantage plans has cost taxpayers tens of billions of dollars more than keeping them in original Medicare, and a cost that has actually exploded since 2018 and is likely to rise even higher. And that's based on research by Richard Cronick, a former federal health policy researcher and a professor at the University of California, San Diego. This was reported by Fred Schulte, now of Kaiser Health News, back in November. Fred and I were colleagues for some time at the Center for Public Integrity, where Fred did incredible reporting on the overpayments to Medicare Advantage plans. This was probably about 10 years ago now, almost. I encourage you to look for some of Fred's reporting, because it just chronicled just how much these plans have been overpaid and how they're getting away with it. Cronick at the University of California, San Diego, estimated that Medicare overpaid the private health plans by more than $106 billion from 2010 through 2019 because of the way the private plans charge for sicker patients. Nearly $34 billion of that new spending came during 2018 and 2019, which were the last payment periods that were available for his research. He was quoted saying they are paying Medicare Advantage plans way more than they should. And he, by the way, had served as Deputy Assistant Secretary for Health Policy in the Department of Health and Human Services during the Obama administration. Nancy Ann, as I'm sure most of you know, would come back to Washington and head President Obama's Office of Healthcare Reform. Critics have argued for a long time that Medicare Advantage costs taxpayers too much. The industry has also been the target of multiple government investigations, as I'm sure you all know, and Department of Justice lawsuits that allege widespread billing abuse by some plans. Chronic call the growth in Medicare Advantage caused a systemic problem across the industry, which CMS has failed to rein in. And he said some plans saw eye-popping revenue gains as a result of their participation in Medicare Advantage and their ability to game the system. He noted that giant insurer United Healthcare, which in 2019 had about 6 million Medicare Advantage members, it has considerably more than that now, that one company received excess payments of more than $6 billion. You might not know this, but it has been such a cash cow for United that now more than 70% of United's health plan revenues come from the federal government or from taxpayers, primarily through Medicare Advantage and those plans that it markets with AARP, Medicare supplement plans, and its participation in the Medicaid program in some states where it manages some Medicaid programs. This is not something that just folks on the left are concerned about. As Joshua Gordon, who is the Director of Health Policy for the Committee for a Responsible Federal Budget, said recently, this is not small change. The problem is just getting worse and worse. Now, that's notable because the Center for the Committee for a Responsible Federal Budget was started by someone I know who was on the board of Cigna for many years, Carol Cox Wade. You would never mistake her for a lefty, but she is still a director of the Committee for a Responsible Budget. And I was going to read something, if I can call it up here. They issued a report. And by the way, not only is she on the board, but my former colleague, Bill Hoagland, who headed government affairs for Cigna for a few years while I was there, is also on the board of the Committee for a Responsible Federal Budget. In their recent report, they said that over the next decade, 2021 to 2030, policies to adjust Medicare Advantage payments more accurately for coding intensity could, number one, reduce net Medicare spending by a range of $198 to $355 billion, with just over half the savings accruing to the Medicare Part A Trust Fund, reduce premiums for Medicare beneficiaries by a range of $32 billion to $57 billion, and reduce the federal budget deficit by a range of $207 billion to $372 billion. And I'm going to read this quote. Addressing this problem would improve the solvency of the Medicare Trust Fund and reduce the federal budget deficits. Given the high and rising cost of healthcare, a number of bold policy changes will be needed to assure long-term affordability and sustainability. In this context, fully adjusting for Medicare Advantage coding practices result in overpayment could be considered an obvious option, particularly because this problem is well known and adjustments are already made. They are just inadequate. And that's right. This is a problem that has been known for a long, long time. So why are we here? Why are we doing this? Why are we talking about this now? It is because these companies are so unbelievably powerful. And they are probably the best in town when it comes to persuading members of Congress and the administrations to play the game in the way that they want the game to be played. They spend huge amounts of money on lobbying. They spend enormous amounts of money on campaign contributions. I know this because while I was at Cigna, one of the things that my team and I did was administer the Political Action Committee, which, by the way, inspired me to do an analysis or some research a few years ago. I started a journalism organization called tarbell.org. One of the things I wanted to look at was which members of Congress are taking the most money from the political action committees of these big insurers. I looked at 5 big insurers, including Cigna and Humana, where I'd worked. It was really quite eye-opening. Among the biggest beneficiaries are Democrats, were then and still are. At the very top of that list was someone who was a member of the Progressive Caucus, Joseph Crowley, who received money from every one of those PACs, and quite a bit of money as well too. He was an influential member of Congress, obviously, and that's the way they understand how the game is played. They spent a lot. They gave him a lot of money, and even though he was the progressive, he was an influential member of Congress. They give a lot of money to Democrats as well as Republicans, and it is why they are able to circulate this letter every year, in which now more than 300 members of Congress sign on, urging HHS and CMS to protect this cash cow for them. It's outrageous, folks. I frankly give put some of the blame on the advocacy community for not paying attention to this and not raising a stink about this long before now. But it's not too late. Getting close to being too late, because 46% of Medicare beneficiaries are now enrolled in Medicare Advantage. Folks, you do not want to know what will happen when it crosses over to 50%. It's going to be game over, or pretty close to being game over. And I think healthcare providers are beginning to realize that's not going to be something that they are going to be all that innocent in that kind of world happening as well either. I'll wrap up for now. I will say that as leader as the executive director of the Center for Health and Democracy, I do want to be a part of exposing going forward, not only these overpayments, but how the industry is conning Congress, the members of Congress, into signing on to these bogus letters to protect their profits. And we'll be doing more of what I did a few years ago that showed Joe Crowley being the biggest recipient of industry money. I'll stop with that. Thanks.
Well, thanks, Wendell. And I think, one thing that's struck me about your research is sort of the straight line between some of these Medicare Advantage overpayments and the increases in revenue, and in particular, new revenue and new enrollment for some of these insurance plans. I don't know if you want to sort of wrap up with one comment on that before Rachel and I jump into congressional and executive action.
Yeah, the big for-profit insurers last year collectively made over $60 billion. A very, very high percentage of their revenues came from the Medicare Advantage program. Humana, United, Anthem, Cigna, Centene, all of them get a lot of money now from the federal government, to the point that, as I think I noted earlier, the majority of their revenues now on the health plan side is coming from the government, from taxpayers. They convert these into profits, and it is why you see Wall Street so pleased with these companies' performance. Their stock price has just gone through the roof over the past few years. The Affordable Care Act, of course, tried to do something to reduce these payments, but not nearly enough was done. So it's definitely time for Congress to really revisit this, take a strong look at this, because taxpayers can't afford this. And your constituents can't afford it. I want to tell one more story. I used to be an advocate for Medicare Advantage plans. I even persuaded my parents to enroll in Medicare Advantage plans. It was a decision I would grow to regret, and so would my mom. She, a year after my dad died, broke her hip and needed rehab. And in the town Kingsport, Tennessee, where she lived, where I grew up, she was enrolled in a United plan. The provider network was very, very skimpy. She was initially at a facility that was in United's network, but honest to God, folks, they were just waiting for her to die. And I think they were planning for her to die. They were not giving her the care that she needed. I did a lot of research and moved mom to another facility that was not in United's network. And I got mom out of Medicare Advantage, but at a high cost, because at her age and her health condition, she couldn't afford she couldn't get a Medicare supplement policy. So it was expensive, but it saved her life because she went on to live another 10 years. I know Mom lived another 10 years because I was able to get her out of that Medicare Advantage plan that had such an inadequate provider network. That's what I don't think many people. I know people don't realize that when they see Joe Namath talking on TV, this sounds too good to be true, and it is something that's too good to be true. It's not true. They never tell you what the downsides are, as Diane was saying, on the undertreatment and the inadequate networks that many of them have, particularly late in life. And that's something also that's been reported and written about, and it costs the traditional Medicare program a lot of money, because when people who are in Medicare Advantage plans transition back into traditional Medicare, that costs the traditional Medicare program money. And the private insurers couldn't be happier because they are getting rid of the people who are costing them the most money. So it's high time y'all do something about this.
Thanks so much, Wendell. And what you said about in the Affordable Care Act that Congress tried to do something about it is a great transition into what Cameron and I are going to be talking about next, which is just quickly answering the question of what can we do, meaning those of us who work in Congress, but also what can the administration do? And so there are a host of things that Congress could do legislatively. And there are some things underway that we're working on, and we would love to have your offices join in on. So legislatively, Congress could prescribe a method for CMS to cut down on these overpayments to Medicare Advantage. And as Wendell alluded to, this was done in the Affordable Care Act, and it set a statutory minimum for CMS to correct these overpayments. Now, that minimum has been used by CMS every year since the Affordable Care Act was passed into law, but a lot of the research that we discussed today shows that the statutory minimum adjustment is nowhere near sufficient to keep up with the upcoding that Medicare Advantage is doing. Now, there are a lot of public health researchers who are even more in the weeds than we are on this, who have come up with a calculation that would adequately correct for these overpayments. And Congress could easily pass a law or language in a larger law telling CMS that they need to use this calculation, but also building in the flexibility so that we're not prescribing a certain percentage, we're prescribing a way for them to accurately calculate the payments to Medicare Advantage. Now, Representative Jayapal did lead a sign-on letter to request this language gets into the FY23 appropriations bill. That letter has closed since the appropriations deadline passed, but if you are interested in that ask or talking more about it, please let me know, because we are definitely pushing on that. But it could also be a standalone bill. There are a lot of other things that Congress can do legislatively that Cameron's going to touch on as well. But I also wanted to mention that there are actions that the administration could take on their own. And that does include correcting Medicare Advantage overpayments. So they do have the authority to correct those overpayments above the statutory minimum in the Affordable Care Act. And there is also another ask that the Congressional Progressive Caucus has of the Health and Human Services Department, and that is to stop the ACO REACH program. And like I said, many of your bosses signed on to a letter urging them to end the direct contracting program, which is what it was called before it transitioned to ACO REACH. And so that is an action that they can take to, again, cut down on the encroachment of these issues. And so now I'm going to hand it over to Cameron to talk a little bit more about what we can do. But I do want to add really quick that for all of the reasons that we heard today, it's really important that we act. But another issue I wanted to bring up is that this really does get at health equity. And that is because a lot of these Medicare Advantage plans will offer plans that either have lower premiums or no premiums, and they make them look very attractive, especially to low-income communities and communities of color. So there's actually research showing that those are the communities that are switching to Medicare Advantage at the highest rates. And so all of the undertreatment, the overcharging, the denials of care that Medicare Advantage is doing is disproportionately affecting those vulnerable communities. And so if we let this continue to happen, if we get over that 50% threshold, it will increase health disparities. So just another reason why it's really, really crucial for us to take action. And so now I'm going to hand it to Cameron for some other steps that we can take.
Yeah, thanks, Rachel. I think you set it up really well. I mean, I think one of the fundamental problems of Medicare Advantage is that we don't know the extent of the problem. We don't, there's the encounter data. MedPAC every year issues a report and says MedPAC is unable to assess the quality of Medicare Advantage relative to traditional or original fee-for-service Medicare. We don't know the performance. We don't know, what are the outcomes? We don't know how many claims are being filed. But the few insights that we do have from researchers who are looking into this suggest that there are some troubling trends, including patients in their last years of life, patients who have costly conditions, transitioning out of Medicare Advantage into traditional or original Medicare. And if that's the case, we have concerns that traditional Medicare and traditional Medicare beneficiaries are subsidizing the low premiums, the no premiums, the supplemental benefits in Medicare Advantage. And we want equity in that sense too. We don't want only the taxpayers on the hook for the costly care, and corporations that are running these programs to only select the healthiest patients to increase profits. But again, we're unable to assess the extent of that issue without the encounter data. Another thing that MedPAC has said is a need to overhaul the quality metrics, which lead to bonus payments to Medicare Advantage plans. Currently, these quality metrics are evaluated at the contract level, and one contract can span several non-contiguous areas. So if a plan has, if a contract covers plans that operate in, say, Georgia, Utah, and Hawaii, all of that data is used to calculate the quality metric. And it's not particularly useful for consumers in, say, Atlanta or Salt Lake City within that need to access the care. So reforming the quality metrics and ensuring that the payments that are made to Medicare Advantage plans are actually tied to consumer satisfaction, health outcomes, and the actual quality of the plans with specificity at the market level is another reform that MedPAC has called for. The HHS OIG report that we've discussed several times, and there's been similar reports in the past, recommended that HHS and CMS issue guidance to plans on the clinical assessments of medical necessity so that consumers know what they're getting into, what types of care requires prior authorizations and pre-certifications. And everyone's sort of on the same page about the types of services that they're delivered. No one's caught off guard when there's sort of an X-ray required before an MRI and care is delayed. So, and I want to stress some other ideas that we have. I think if we reform some of the overpayment issues, especially with coding intensity, upcoding, that can go to fund or even serve as an offset for additional benefits that could improve traditional Medicare coverage and still have money left over. We're talking hundreds of billions of dollars. Traditional Medicare has a broader network of providers that patients are able to see. And if we can expand and improve and strengthen that, rather than, errantly funneling hundreds of billions of dollars over decades for private profit, we can serve to strengthen traditional Medicare. I think the last thing is, I don't think anyone is saying that, Medicare Advantage should go away tomorrow. It's 46% of beneficiaries. This is a very large and important program. Our position is that, to warrant the continued investment, the continued public investment that Medicare Advantage plans have, we need better information. We need to know that it's delivering a return on what we're putting in as taxpayers and as lawmakers, who continue to do this. So that's just one thing, as proposals for Medicare Advantage reform are circulating and or as letters of support for Medicare Advantage are circulating, just consider the extent to which we actually understand where the benefits are going and what the, how well we can understand the problem. So I think, that is where I think we'll end it for now as far as sort of actions, and I'll turn it over to Will.
Cameron, thank you so much. And Rachel, Wendell, Diane, can't thank you enough for taking the time out of your day to be a part of this extraordinary briefing today. And to all of the registrants, thank you so much for taking the time to join us today. And I would just, before we get to the questions, I would just ask that in the wake of the briefing today, that you not hesitate at all to reply to the note that you got from me earlier in the week, or along with your registration today, with any questions or any sort of further conversation you wish to have. We welcome the opportunity and look forward to working with you.